Thank you, Sue. Good afternoon, everyone, and welcome to this third in a series of webinars on asthma and COPD. As Sue said, I am currently the Director of Commercial Care Management here at Priority Health and have worked in the field of asthma for over 30 years. As a manager of the Asthma Network, I've also worked I'm also a nurse practitioner, and I worked in a private allergy practice for almost 10 years, serving patients with asthma and allergies. I have asthma myself, and I have a daughter with asthma, so as I like to say, I live and breathe asthma every day. And today's webinar is going to be about asthma triggers. So we'll be talking about asthma triggers, environmental triggers, and others, indoor, outdoor, all different types of triggers. And as you can see from my picture there, there's nothing wrong with babies and puppies, but coming from my perspective in asthma and allergies, I do find that a little bit troubling if that baby has any genetic predisposition to allergies. That could be a recipe for trouble down the road. So we will be talking about that shortly. So asthma triggers essentially are a variety of stimuli or triggers that can cause airway inflammation, swelling, and bring on an asthma flare. So it's anything that can irritate, aggravate, or trigger an asthma exacerbation in an individual who has asthma. So obviously, it would make sense that by eliminating or reducing exposure to triggers, and the more triggers we can eliminate or reduce, the better off we're going to be, and decrease the need for asthma medications, reduce symptoms, and hopefully prevent asthma exacerbations, prevent emergency department visits, hospitalizations, and most certainly we want to prevent asthma deaths as well. So an asthma trigger is, again, as I said, an agent or a factor that contributes to asthma severity. Now, what we find is that asthma triggers in most people who have asthma are additive in nature, and that's why I have the building blocks there, the baby building blocks. I have asthma, as I said. I developed a cold about a month ago, and I've been battling with some asthma exacerbations since then because that virus left inflammation in its wake. So because of that, because I have the cold, I'm more sensitive to other asthma triggers. So typically I can run up a couple flights of stairs and I have no problems with that. Because I have this inflammation as a result of that exacerbation, I'm having more shortness of breath with activity right now. And when I go outside and if it's cold out, that may also contribute to some more asthma symptoms. So perhaps a child goes to school and they are allergic to dogs, and someone brings in a dog, or they're allergic to cats and they bring in an animal for show and tell, and they may not have a trouble on any given day. But if you add to the mix, perhaps that they have a cold starting, or they just came back from recess and they were very active during recess and they're having some asthma symptoms, and the more triggers you add up, the more likely it is to spill over and cause an asthma exacerbation. I liken it to almost a teacup. So those individuals out there who don't have asthma, your cup is empty, and we can fill in as many triggers as we want throughout the day or week, and I wouldn't expect you to have respiratory symptoms. Those of us who have asthma, our cup is already half full. And so the more triggers that we fill into that cup, the more likely we are to fill it up to the top, it will spill over, and that's when we have asthma symptoms, asthma exacerbations. Also, there's people can have different sensitivities. So I may be sensitive to pollens or cold air or exercise. Someone else with asthma may be sensitive to one or all of those, or maybe none of those, and they have their own sensitivities. So that can really vary by person to person. We also find triggers in a variety of locations. They can be asthma triggers can be anywhere, home, school, workplace, outdoors, in your car, and entertainment venues, anywhere humans exist, there could be asthma triggers. So we do talk about a stepwise approach. Just as we do for asthma medications, there's also a stepwise approach to managing asthma triggers. So we say, let's at least start with the bedroom. We'll talk about that shortly. Let's ensure the bedroom is as asthma safe as possible, and then we can also roll that out to the rest of the house. But let's focus on where we sleep for 8 hours a night. So there are various categories of triggers, and we'll talk about these. There are allergens, there are irritants, respiratory infections, upper respiratory infections, viruses, colds, exercise, weather changes, stress, and there are other triggers like gastroesophageal reflux disease or GERD, obesity. We'll even talk a little bit about pregnancy at the very end. The one trigger that we don't want people to avoid on this list, obviously, is exercise. And if your asthma is well controlled, you should be able to exercise and be as active as your peers are and as active as you wish to be. It shouldn't hold anybody back from being active. Now, as I said earlier in the previous webinars, I have tried to add updated information here from the GINA guidelines, the Global Initiative for Asthma from 2017. And as far as triggers, there were probably more updates on the diagnosis piece and pharmacology piece, and even next time on the asthma action plans. But for triggers, they typically don't change as much. So I will just list them out here. Oh, these are triggers that were noted in the GINA guidelines from this year. I will address most, if not all of these, in greater detail throughout the webinar, but just listed them here, like tobacco smoke exposure, physical activity, occupational asthma, medications that can worsen asthma. We know that there are medications that can trigger asthma in susceptible individuals, especially NSAIDs, non-steroidal anti-inflammatory drugs like Motrin and ibuprofen, aspirin, that sort of thing, or beta blockers, dampness or mold in the homes or other locations, schools, etc. We also talked about sublingual immunotherapy. This is a new form of immunotherapy where you put the medication under the tongue and you use that for 3 months leading up to pollen season, and then for the 3 months of pollen season. And that has been found to be of benefit in some individuals who have asthma. Allergen immunotherapy can also help asthma in allergic individuals. Vaccinations, we absolutely support the annual flu vaccine. We're going to be talking in just a minute about the hygiene hypothesis, also weight reduction for obese patients, breathing exercise, dealing with emotional stress, and finally we'll be talking about indoor allergens and outdoor air pollutants as well. So just touching on the hygiene hypothesis, this has been a theory that has really moved into more of a proven concept for at least, I want to say 10 to 15 years, where people are realizing and researchers are realizing that, we are certainly seeing, as I talked about in the first webinar, an epidemic of asthma. And I mean truly an epidemic of asthma in the last 10, 20, 30 years. We're seeing more people diagnosed with asthma than ever before, and we're seeing that in just incredible numbers. And we were wondering, of course, the question is why? And people ask me that all the time, and I say, well, if I knew why, I probably would win the Nobel Prize for Science, because nobody really knows why. But we do know that there's simply more asthma out there. We know more people are developing and being diagnosed with it. One of the theories is, and again, this is being considered now more proven concept, that in the developed industrialized nations, we tend to have perhaps smaller family size. Obviously, we would hope to, with a cleaner environment, have less exposure to parasites, fewer infections. There certainly is more antibiotic use, less exposure to farms. The rural areas are smaller and urban areas are growing. So the end result is we have fewer microbial exposures. And when a baby is born, within the first year or so, their immune system is immature. And then the first year, that immune system usually converts to a more mature immune system. If it is not challenged by, and I'm not talking just in the first year, but certainly the first couple of years, if that immune system is not challenged by infections, if it's, for example, if the child is an only child and they're not put in daycare and perhaps not living on a farm, etc., the theory is that the immune system is left with nothing to challenge it. It tends to turn inwards as asthma is considered an autoimmune disease, and it leads to the more allergenic and pro-asthma pathway. On the other hand, you have developing nations that we might see more families that have multiple children. They are maybe exposure to parasites, more infections, less antibiotic use. More tend to live on farms. They have a high microbiological exposure, and that does challenge the immune system. So their immune systems convert, and they follow the non-allergic or non-asthma pathway. So as an example here, and this was actually a study that was just published in 2016 in the New England Journal of Medicine. And the question is why, or the declarative statement here is why the Amish don't get asthma. And I think that picture, it says a lot. So why they don't get asthma is that Amish children are exposed to barnyard germs, and they tend to have much lower rates of asthma than kids raised in more sterilized environments. So the microbes actually challenge or activate their immune systems, and the theory is, the belief is that it protects them against asthma. So they said, okay, well, if that's the case with the Amish children, what about the Hutterites of North Dakota? They share very similar genetic backgrounds. They have the very same simple lifestyles. they found a much higher rate of asthma in the Hutterite children because the difference was in how they farmed. There was a much lower asthma rate in Amish children, 2 to 4%, and the Hutterites, you could see, was almost 5 times the rate of those in Amish children because they live on more industrialized farms. They do utilize electricity. The cows are housed in huge barns that are much farther away from their houses, whereas in the Amish communities, sometimes the barns are actually attached to the house and the children sleep in the barns. So that type of exposure is believed to be the difference in children otherwise of very similar genetic backgrounds and very similar simple lifestyles. I thought that was very interesting to see that. So let's talk for a minute then about allergens and irritants. So these are the classic classifications of environmental triggers. So indoor allergens would include animals, dust mites, cockroaches, molds. Outdoor, you can see the various types of pollens, tree grass, weeds, molds. And then in irritants, we can see certainly environmental tobacco smoke, combustion byproducts from wood smoke, air pollution, products that are scented, and cold air. So let's begin talking about indoor asthma triggers. And what you'll see here, I heard an indoor asthma trigger expert refer to this as the Annette Funicello phenomenon. Now, many of you may be way too young to be familiar with the Mickey Mouse Club or to know who Annette Funicello was. But the theory is that in the 1950s, the Mickey Mouse Club came on the air, and prior to that, children spent most of their time outdoors. With the advent of television, children came indoors, and they've really never left because after television came all types of other indoor entertainment, and then there were games, and then there were video games, and then computers came to be, and now cell phones, and everything these types of things are keeping children indoors. So we're actually more than a couple of generations ago when they were outdoors, 90% of our time is spent indoors. So it's not that we're blaming the rise of asthma on poor Annette, but the belief is that because of the change in our culture and the way we live, that people are simply spending more time indoors. So when you're indoors, the outdoor pollutants come inside, the pollutants are added to indoor air, and the end result is that these are respiratory irritants. There are also allergens coming in from outdoors. There can be fetal effects involved as well. So the belief is if we can reduce the exposure to indoor allergens and irritants, we can reduce asthma symptoms. So prevention is really a key asthma management tool. So let's begin with triggers. So a trigger is a condition in which the body's immune system overreacts to a foreign substance that's been breathed in, swallowed, touched, or injected. So in most cases, in virtually every case, if someone were to breathe in pollen, if you don't have an allergy to pollen, it is totally benign. It won't affect you in any way. But if you should have a pollen allergy, for example, to ragweed, and you breathe in or touch ragweed and ingest it somehow, your body will mount an overwhelming response. Your body identifies that otherwise harmless or benign substance like pollen as an invader, and it mounts this overwhelming immune response and reacts and overreacts. And that's when we get nasal symptoms, which can trigger asthma symptoms. So approximately 70–90% of the children with asthma have allergies. 50% of adults with asthma have allergies as well. So it is very, very common to see asthma and allergies, and they do go hand in hand in children in particular. Then let's talk about pets for a minute. So with pets, the allergen is located primarily in the dander and in their urine, feces, and saliva. So it really doesn't matter. I can't tell you how many families would say to me, I have a short-haired dog. I have a Chihuahua. My dog doesn't have much hair, so I can't be allergic to him. It's not the hair. You can have a long-haired, short-haired dog. They all have dander. Dander are the skin cells that they flake all day long, and that's what are so highly allergenic. And those allergens are present even in homes and public places that don't contain animals. They actually found cat dander on the space shuttle, not because there was ever a cat on the space shuttle, but because the astronauts brought it in on their person. And if you can imagine what you would find in a school setting with kids bringing in the dander on their persons, on their clothing, the allergen load from pets is almost overwhelming in a school setting. So the goal is, again, we can't do a sweeping change in many homes and just say it's impossible to clean out all the dander in the home. So we recommend to keep the pet out of the main living areas and the bedrooms in particular. Install a HEPA air cleaner in the main areas in the bedrooms. If we can avoid furry and feathered pets, or products made with feathers, we'll be a step ahead as well. But we really want to focus on the bedroom. We spend a third of our lives in the bedroom, 8 hours a night. So if we can create a safe sleeping environment for asthma, we're going to be a step ahead. So when someone does encounter allergens throughout the day, it may not impact them as much. So we recommend using a vacuum cleaner with an integrated HEPA filter and double thickness bags. There may come a time when, despite our best efforts and despite allergen avoidance, that child or that adult still may have uncontrolled asthma because they have that allergy to their animal or to their pet, and how heartbreaking that is. But it may be necessary at some point in select cases, not every case, to remove the pet from the home if there is no other way that we can get asthma under control. We actually had to do that when my daughter was 3. We actually removed our dog from our home and we rehomed him. And our allergist was incredulous. He said, "I can't believe you got rid of the dog." I said, "Well, my daughter's asthma is out of control and you recommended this and I did it." He said, "I have children in the hospital on ventilators and the parents won't get rid of their pets." So you have to, look at your priorities, and you do what you have to do for your kids. So there is also a website, petfinder.org, and that is a website for adopting and fostering animals, and they will not destroy the animals if no home is found. And then even if the animal is removed and you clean that home aggressively, it can take up to 6 months to completely remove all the dander in the home. Now, there is also controversial studies that have shown that perhaps pet washing can be effective. Others have said it's ineffective. It can't hurt to certainly wipe down a dog. There are pet wipes you can pet stores. Anything you can do to minimize the dander in the home. Of course, this is another example of pet washing. This might be something that a cat would prefer, a cat shower. Another animal that you may find in certain homes are rodents, mice and rats. And the rodent proteins are potent sources of allergens, and you will find that many children in inner cities will test positive to mice and to rats. Their major allergens are found in their urine, and what we find is that they accumulate in very high quantities in the litter. So there was a national inner city asthma study that was a landmark study done in 2003, and they found that a third of all inner city homes had rodent dander and rodent allergens in the home, and 21% of those children in those studies tested positive to rat sensitivity, and 21% of that dander allergens and urine proteins were found in the bedroom. So they did recognize that this was related to missed school days, ER visits, and hospitalizations. Dust mites, however, would be considered the #1 indoor allergen. So dust mites are these little microscopic creatures. Now that obviously is blown up quite a bit, the picture on here, because otherwise you really cannot see them with the naked eye. They're very tiny. But these little creatures actually live in upholstered furniture, in carpeting, upholstered chairs, but they really, really multiply, especially in beds, because their major food source are our skin cells that we shed all night long, and that's what they eat. So they really accumulate and they proliferate in beds and pillows especially. Their major allergen is contained in their fecal pellets. So and one of the allergists that I work with used to call it dust mite poop. That's what is so highly allergenic, these fecal pellets. And they really proliferate, again, in bedding, in mattresses and box springs and pillows. And what happens is when you then lay on the bed, the particles are disturbed and then they settle in, and it's a perfect time for you to inhale or ingest them and become sensitized to them. And that's when someone with asthma or allergies who has that sensitivity can develop symptoms. So we recommend making the bedroom asthma safe. It's not possible to eliminate all dust mites. It's just not. They exist anywhere there are humans. But if we encase the mattress, the pillow, and hopefully the box spring as well, if the family can afford that, in allergen impermeable covers, that will actually protect them from the dust mites and the fecal pellets in the mattresses. Also installing a HEPA air filter in the bedroom, which is a portable air filter, will also help. Reducing clutter, cleaning and dusting weekly, and then sometimes it gets to the point where they might have to remove the carpeting. Also, reducing the indoor humidity to less than 50% is helpful because dust mites also proliferate in very humid environments. So we do recommend using humidifiers or vaporizers with caution in individuals who have asthma, because that just really leads to more dust mites. Washing bed linens weekly in hot water, minimizing upholstered furniture, using blinds instead of, using shades instead of blinds because they're easier to wipe down. Also, you know, lots of kids enjoy many dusty types of soft toys and stuffed animals, and we don't necessarily want them to eliminate all of them, but what you can do is certainly wash them, because they also do harbor dust mites, or you can actually put them in the freezer for 24 hours, and that will also kill the dust mites in them. And as I said, sometimes removing the carpets becomes necessary. Cockroaches, also another significant indoor trigger, and people don't realize that cockroaches are highly allergenic. It is the allergen is found in the cockroach saliva, in their feces, and in their skin shedding and dead bodies. So even if you were to have an exterminator who came in and killed all the cockroaches, when those carcasses, those bodies lay and they decompose, that actually can lead to more cockroach allergen in the home. So it really needs to be cleaned up quickly. And levels in the bedroom are most associated with sensitization and disease. Many inner city schools have roaches, and cockroaches are the dominant indoor allergen in many urban areas. So the best predictor of asthma morbidity in that inner city asthma study was exposure and sensitivity to cockroaches. So controlling cockroaches, I won't list all these out here. That's why I said in the last webinar, I do have a lot of text on these slides that you can refer to. This is more of a reference for you. You can see the recommendations here. The one thing I would say is to use caution in using an exterminator, because sometimes they can use toxic substances that can also affect individuals with asthma. So there are more environmentally friendly ways to eliminate cockroaches that we could consider using that may not affect the individual with asthma. Molds can be found indoors or outdoors, and they reproduce by making and releasing mold spores. And they can be very tiny. They can range in size from 2 to 100 micrometers. It's very tiny, and that's very respirable. So you can easily breathe that in, and it gets into the lower bases of the airways. So the spores become airborne when they're released by the mold, and then they're disturbed through physical contact. Mold allergy, again, is related to asthma, and asthma severity in children and adults is related to allergic rhinitis. And we want to minimize the high humidity and dampness in the home. Mold can grow in heating, ventilating, air conditioning units. So we do recommend dehumidifiers as well, and keeping the interior dry. We also recommend repairing leaks quickly, cleaning moldy surfaces. Again, another reason to reduce indoor humidity is to minimize the risk of mold growing and developing. Carpeting on cement floors in the basements, for example, many schools. If there's ever been water intrusion on that cement floor with the carpeting on it, there's almost assuredly some mold growing on there as well. So sometimes professional mold testing is indicated, but using bathroom and kitchen exhaust fans can help, and just making sure that there is no water intrusion and these leaks are fixed and repaired very quickly. So we'll move on from allergens to a minute to irritants. So the difference with it, remember that allergen is something that you breathe or touch or ingest, and the body mounts this immune response. With irritants, an airway irritant is also something that can be inhaled. It triggers inflammation and bronchospasm in individuals with asthma, but there's no allergic component. These are just substances that are highly irritating to an individual with asthma who has such sensitive airways. So, of course, this is my theory as well. As Gary Larson, the real reason dinosaurs became extinct, we're going to begin with smoking. So tobacco smoke is a universal irritant. I truly don't know many, if any, individuals with asthma who are not triggered by smoke, even individuals with asthma who smoke themselves. I took care of many patients like that in the allergy office, and understandably, their asthma was almost always out of control, and I would tell them, very frankly, there is no way that we can get your asthma under control and keep it under control if you continue to smoke, because every time you light up, you are actually causing that airway inflammation, and you're counteracting all the good that the medicine is doing. It's difficult, if not impossible, to get asthma under control in a smoker. So there's active smoking, but then there's also passive smoking, people who are exposed to environmental tobacco smoke, especially children. Because the tobacco smoke itself contains 4,000 substances, and over 40 are carcinogenic. It causes profound irritation of the upper airway. It leads to increased incidence of lower respiratory tract infections, increased frequency of asthma exacerbations. And there's even some studies that have shown that children without the genetic predisposition to asthma may develop asthma if they live with smokers. So it is a profound irritant to the airways. So it's very difficult, very touchy, very sensitive to work with either patients or parents or caregivers of individuals with asthma. So a realistic, supportive approach, but also don't underestimate the impact of a health professional saying to them, you need to stop. You need to stop for your own health, or you need to stop for your children's health. And again, until you stop smoking or smoking in the home around your child, it will be impossible, difficult if not impossible to get their asthma under control while they're exposed to that. So educate them about the negative health effects of smoke exposure, and then try a practical plan of control. So I would not certainly mandate, and even if I could, it wouldn't work. I would never ask parents to quit smoking. I would ask if they were interested and I would help them. But otherwise, I would just say, I would like you to take your smoking outside. Never in the car, never in the home, whether the child is there or not, because the smoke lingers in the air for hours. It can trigger them when they get home. So always smoking outdoors. And then even to the greater extent, to use a smoking jacket. And I don't mean, a velvet jacket with an ascot. I mean a jacket, something that you would wear outdoors, hang up in the garage or on the porch, and then come in so you don't carry that odor and those particulates in with you. Never smoke in the car, and choose smoke-free childcare settings as well. Now, cotinine is a way that we can actually measure how much tobacco a child has been exposed to, because it's a major metabolite of nicotine, and it can enter the body of a non-smoker. And it can be measured by cotinine levels in the blood, saliva, or urine. It's a preferred measure of exposure over nicotine because cotinine remains in the body longer. It has very long half-life. And it's highly specific for tobacco smoke. So studies have found that children with asthma with high levels of smoke exposure, this makes perfect sense, are probably going to have more moderate or severe asthma, more difficult to control asthma. So it can get to the point, and we have done this in the past, that if a parent or caregiver or guardian refuses or simply can't stop smoking around the child, and the child suffers as a result of that, and by suffers I mean frequent emergency department visits or hospitalizations, then at some point, that if we are able to get a cotinine level on that child, that could rise to the level of medical neglect. So that's why there are certain levels of detection. And if a child is experiencing asthma exacerbations as a result of being exposed to nicotine, we can do these cotinine levels and measure how much they have been exposed to. And if it rises to a certain level, that may qualify as a case for medical neglect. So other airway irritants, other sources of smoke, fireplace, stoves, heaters, wood-burning stoves, campfires, outdoor fires, leaf and grass fires this time of year, certainly outdoor pollutants, other irritants, and we'll talk about those shortly too, perfumes, cleaning agents, sprays. So even pleasant smells like potpourri or plug-ins can also trigger asthma in sensitive individuals. And we're talking about chemical odors here. So paints or solvents or pesticides, dry clean clothes. When I take something home from the dry cleaner, I would take the plastic bag off and I would let it air out in the garage for a day or two before I brought it in the house, because that odor would irritate me and would irritate my daughter. Cleaning agents, you want to try and use environmentally friendly or green cleaning agents, but certainly even perfumes or colognes, as I said before, plug-ins and air fresheners, even pleasant smells, anything with a strong fragrance can trigger asthma in an individual who has sensitive airways. Work-related asthma is another form of an irritant or a trigger for someone with asthma. So this is asthma that's caused by the work environment, exposure in the work environment. And one way that we're able to detect that is, for example, someone improves when they're on vacation or on their day off, or they are fine in the morning and they get progressively worse as the day goes on, or they are fine on Monday and they get worse as the week progresses. Excuse me, we can ask them to do peak flow monitoring, for example, and if their peak flow drops considerably, more than 20% between work and non-work, that can suggest occupational asthma. It's not always realistic to ask someone to quit their livelihood. So sometimes when someone would come in with work-related asthma in the allergy office, we would ask if they could be reassigned to a different location or to wear a respirator or something that would help protect their airways. Let's move into outdoor asthma triggers. So pollens certainly are very much an issue in certain seasons of the year, and we want to limit exposure during that season by staying indoors with the window closed if possible. During certainly the high pollen times of day, which are typically midday. But also now the local weather forecasts are very good about telling you pollen counts, and that might give you an indication when to use air conditioning if possible, if the family can afford that. But also optimizing allergy meds like antihistamines and other allergy meds. A very simple way to deal with that as well is when the child comes indoors, or an adult, even outdoors all day long, you have pollen allergy, simply shower, because pollen is very sticky. It sticks to the hair, it sticks to the skin. So showering before bed will actually remove a lot of that exposure and hopefully reduce symptoms and reduce an exacerbation. So allergic rhinitis, studies have shown that inflammation of the upper airway contributes to lower airway symptoms. So the theory is that it's a unified airway disease. It's all one airway. And my response to that when that initially came out was, well, duh, of course it is. It's all one airway. So if someone has inflammation in the nose from allergies, and they have asthma, there is no line of demarcation, no demilitarized zone. There's nothing there that says, okay, we stop here. Of course, the inflammation can very easily and often does progress from the nose all the way down into the respiratory tract. So if we can treat the upper respiratory tract, that really is thought to be an integral part of asthma management. So symptoms of allergic rhinitis can include sneezing, runny or itchy nose, congestion. You might see clear discharge from the nose on exam. You might see a crease in the nose from a lot of nasal rubbing. You might see dark circles under the eyes as well. And if you were to look into the nose, and I can't tell you how many times I saw this, you would see inflammation of the tissue lining of the inside of the nose. And sometimes it was almost completely occluded. And you wonder how people can breathe through that, and they often can't, and they become mouth breathers. So this is provoked by allergens, can be seasonal. So we're talking about pollens like tree grass weeds pollen, or it can be year-round. People can have the type of response to molds or dust mites or animals. And this rhinitis can increase their sensitivity to other triggers. We talked about triggers being additive. So if someone is having allergic rhinitis, that can make them more sensitive to other asthma triggers. So treatment includes avoiding offending allergens, nasal irrigation with saline, so the nasal rinses are very helpful, oral antihistamines, decongestants, and inhaled nasal steroids. So the symptoms that you'll see, I won't go through all of these, but you can see itchy, watery eyes, sneezing, postnasal drip, sore throat, watery, profuse nasal discharge, ocular symptoms, fatigue. So people who have nasal allergies really don't feel well. I mean, they're very fatigued. They just feel congested. They feel miserable. You can see the child on the upper left. Those are called allergic shiners, those dark circles under their eyes. The child on the lower right, that's called the allergic salute, because they're rubbing their nose so frequently. Some kids actually get a permanent crease at the bottom, the very tip of their nose, because they're just rubbing their nose all the time. They don't even know that they're doing it. They don't realize that they're doing it. So the Joint Task Force on Practice Parameters, Allergy, Asthma, and Immunology have said that nasal steroids provide the most effective symptom relief of allergic rhinitis. But when you do that, correct technique is critical, because a lot of people throw their heads back and spray it in their nose and they're good to go. But you really need to shake the container well, tilt the head forward. You want the nose over the toes, and then you want to direct the nozzle away from midline. So sometimes I would even say you take your right hand to your left nostril and your left hand to the right nostril, because that automatically angles it toward the outside of the nose. Then you want to spray and sniff, spray and sniff, and then repeat and repeat. And you want to use the saline sprays before and not after the corticosteroid spray, because obviously that'll flush all the medicine out of the nose. So just a couple quick lists here of pharmacologic treatment for allergic rhinitis. And you will see that antihistamines block the histamine receptor, intranasal steroids are anti-inflammatory, cromolyn sodium is a mast cell stabilizer, decongestants, they cause vasoconstriction and will help open up the passageway. And then there's also antihistamine decongestant combinations. And here's just a couple names, just so you're aware of them. These are available. Many of these are available over the counter. Some of them are only by prescription. In my 10 years in allergy practice, a lot of these, when I started, virtually every one of these except for the older generation like Benadryl and chlortrimeton were available by prescription only. Since then, almost all of these are now available either by prescription or over the counter. And you can see the generic and the trade names on the right. Allegra, Zyrtec, Xyzal are the newer generation antihistamines, so they can work well. They're thought to be less sedating. And then you have something like Benadryl, chlortrimeton. Those are the older generation antihistamines that are very effective, very dry, but very sedating. And then there are a couple nasal sprays that are also the antihistamine nasal spray as well. And then the inhaled nasal corticosteroid sprays. You can see the generic on the left, trade names on the right, and those in red are also available over the counter. A couple newer ones, and it's not so much that the medication has changed, they're just different molecules, different forms of nasal steroids, like Q-nasal, but a little bit more in the delivery system. So Q-nasal is waterless, Maris and Zetona are aerosol, and then finally Dymista is actually the first combination nasal spray. It combines an antihistamine and a nasal steroid in one nasal spray. Of course, this is an old-fashioned way of dealing with allergic rhinitis that may or may not work for some. And how do we know who is allergic and what in particular you're sensitive to? The best way to do that is with allergy testing. Skin prick tests are the most common and the most sensitive, and you can test a wide variety of allergens. They're most convenient and specific screening. They may be a little less sensitive than the intracutaneous. So what we would do is when someone came in, we would do the allergy testing and on the back, and we would test babies down to age 6 months. We would look sometimes for pet allergen or food allergies, that sort of thing. You can put multiple tests on the back at once in children. Otherwise, for adults, older children, adults, it's done one at a time. And we watch what is on the back for about 15 minutes. Whatever is negative in, not in babies, but in older children and adults, we can move on to part 2 on the arm, and that was the intracutaneous. That was more subcutaneous, and that would give us a better idea of what truly they were sensitive to. So they're not necessarily diagnostic that really should correlate with their patient's clinical history, but they are very useful too for demonstrating sensitivity to not only the patient but the parent, because I would be able to point out to the spot on the back and say, see this huge wheal on the baby's back here? That's dog allergy. This is telling us this child is allergic to dogs or whatever the substance was. There are also blood tests that are available if an individual cannot or will not undergo the skin prick test. So when do we consider allergy immunotherapy? If there's a clear evidence of a relationship between symptoms and exposure to something that's unavoidable, and the patient is sensitive to that, it can be very helpful in reducing that sensitivity and also helping with allergic asthma, especially if there's an allergic response most of the year or a major portion of the year, and we're not able to get allergies under control with standard pharmacologic treatment. There is significant potential benefit from immunotherapy, and that is typically started in children who are 5 years and older or adults. And then we talked last time about sublingual immunotherapy or SLIT, and that's also available for grass and tree pollen and ragweed pollen. Started 3 months before the season, taken throughout the season. The first dose is given in the office. They're observed for 30 minutes. Then they administer it daily at home, and it's recommended that they have an EpiPen on hand. So again, allergen immunotherapy is effective for allergic rhinitis, allergic conjunctivitis, allergic asthma, and also stinging insect hypersensitivity. So someone with a bee sting allergy, it can certainly reduce their risk of having a major or anaphylactic reaction if they undergo the entire sequence of allergy immunotherapy for that, whatever they're sensitive to. Most patients need a combination of available therapies because it does take up to a year to get the full benefit. So we would not recommend they stop their allergy medicines. They get these injections weekly for 4.5 months while they're building, and then the cadence switches to monthly for 3 to 5 years. And we talked earlier about the immune system, and the evidence suggests that this mechanism may involve immune deviation from the Th2, which is the pro-allergy pathway, to a Th1 response to an allergen. Weather changes are another trigger for asthma, and the effect is not the same in all seasons. In fall, we notice a dramatic increase. There's actually a phenomenon known as a September spike, where we see a much greater incidence of asthma ER visits. And the thought is sometimes with the weather changing, dramatic changes from day to day, people start turning their heat on, and that gets dust circulating to the home. Children go back to school. They're exposed to those first colds or flu viruses of the season. We probably see fewer ED visits in the summertime. Spring, again, a lot more variability. So there is definitely a seasonality to asthma as well. Cold air is also a well-known airway irritant in the wintertime, especially those with exercise-induced bronchospasm. But also, some people have trouble on hot, humid days. And the thought there is perhaps there's more mold in the air on those real humid days. And even on windy days, pollen and mold spores become airborne and are more likely to be breathed in by susceptible individuals. Air pollution, when you see those ozone action days and you see the color-coded days where it gets to the point that it's orange or red, it's not safe for individuals with respiratory conditions. That's because the pollution is a phenomenon where we see a weather inversion, so it's where a weather system sits still and it concentrates all the airborne pollutants on one community. And I'm based here in Grand Rapids, and we tend to be in a valley, so we are really prone to that. And we get pollutants flowing in over Lake Michigan from Chicago and Milwaukee. They concentrate over this valley here, and then when you have the heat and the sunlight focusing on it in the summertime, it reacts with these pollutants and creates a large amount of ground level ozone, and that is a well recognized asthma trigger. So it's more likely to occur in larger cities, and pollution can certainly worsen asthma. It does act as a significant, profound airway irritant. So watching the weather can be helpful. We can talk about ozone action days. You will actually see pollen counts now, mold counts, oftentimes on the weather, and there are ways that you can minimize that by limiting the time of day you exercise, or wearing a scarf or a mask, or staying indoors on peak pollen days or windy days, and keep a symptom diary. So we're going to finish up here with a few last asthma triggers: obesity, exercise, GERD, respiratory infections, and pregnancy. So there is a known obesity asthma link. The problem is we don't necessarily know which way it goes, and it may go both ways. It's not clear whether obesity contributes to asthma or asthma contributes to obesity. We do know that they coexist in many people, and that contributes to inflammation. There seems to be a synergistic effect. And when people with asthma are obese and they lose weight, their asthma tends to improve. Maternal obesity and pregnancy is associated with a higher risk of asthma in children. And we do know that obesity is the risk factor for asthma and is also associated with increased asthma severity. But on the other hand, if someone has asthma and it's not well controlled and they are not as active as they were before, and they really ratchet down their activity level, that can also contribute to obesity as well. So asthma is more difficult to control in obese patients, and they have many comorbidities like obstructive sleep apnea and GERD, and sometimes a lack of fitness or reduction in lung volume because of the obesity is due to the abdominal fat, and that can contribute to dyspnea as well. So for management, we do recommend a BMI for all patients with asthma, confirm a diagnosis of asthma with spirometry. Inhaled corticosteroids are still the mainstay for persistent asthma, although the belief is that response may be reduced in individuals who are obese, and they may respond to leukotriene receptor antagonists like Singulair. And weight reduction, we know by research, it does improve asthma control, lung function, and health status, and may reduce the need for medication. Exercise-induced bronchospasm. So 90% of individuals with asthma have exercise as a trigger. The theory is that it's caused because we're breathing more rapidly during exercise, so there's more loss of heat and water from the airways during exercise. And the airways don't like cold, dry air that you're breathing in. The airways like warm, moist air. So when the air becomes cold and dry, that is triggering asthma symptoms. It results in airflow obstruction. Diagnosis can be an exercise challenge where there is serial spirometry conducted before and then after exercise and at 5-minute intervals for 20 to 30 minutes. Symptoms can include cough, shortness of breath, chest pain or tightness, wheezing, or endurance problems during exercise. And just because someone does have exercise-induced asthma, it doesn't mean that they can't exercise. They just need to prepare for it. There are Olympic athletes who have won gold medals who have asthma. So it shouldn't keep anybody from being active. They need to know how to manage it and how to prepare for it. So obviously you're going to avoid exercise if you have asthma symptoms present, but they may need to pre-medicate with albuterol. They may need to warm up and cool down, maybe a modified form of exercise. There needs to be a period, as I said, of a cooling down, breathing through the nose, exercising regularly will also keep them conditioned, and then getting adequate rest and drinking fluids. So there's certainly the elite athletes have learned how to work through that and how to manage their asthma to the point that they can be world-class athletes. So GERD, or gastroesophageal reflux disease, is where acid from the stomach contents stimulates the nerve endings in the esophagus, and that can cause a chronic cough. It doesn't necessarily mean asthma, but it can trigger asthma symptoms in susceptible individuals. So symptoms of heartburn are that sour taste in the mouth, where you get the acidic materials in the mouth. They can also enter the airways and trigger an asthma reaction. And that's thought to be one of the possible reasons why people with asthma may have more difficulty at night. So if someone does have asthma and they complain of more asthma symptoms at night, one of the things we would look for is the possibility of reflux. And if you look at the stomach here, you can see it is a combination of conditions that increases the presence of asthma in the esophagus, and asthma, as we all know, doesn't belong in the esophagus. But there is a transient relaxation of the sphincter, the lower esophageal sphincter, and that causes a delayed gastric emptying, decreased salivation, and impaired esophageal clearance. And then you get this backup of the stomach contents into the esophagus. And lifestyle factors also play a role in that. So that would be risk factors like smoking or large meals, fatty foods, caffeine, pregnancy. People are more prone to GERD then, obesity, even body positioning. There may be more GERD when you're lying down than sitting up. Certain drugs can lead to that, as well as hormonal changes. So how does GERD actually trigger asthma? Well, somehow the reflux material gets past that sphincter, and then it can be aspirated into the larynx and tracheobronchial tree. So the belief is these symptoms may be caused by one of two ways or a combination of both, either direct aspiration of the acid into the bronchial tree, and that usually happens during sleep, or indirectly, we have this acid leaking from the lower esophagus, and that stimulates the vagal nerve, and that triggers bronchoconstriction. So one of two ways, or possibly both, a combination of the two. So recommendations, don't smoke, don't drink alcoholic beverages. They increase stomach acid, as does caffeine, as does chocolate. Avoid carbonated drinks, the other foods that you can see there that can also stimulate the increased acid. Wait before, after eating, before bending over, lying down, or going to sleep, so don't eat a big meal right before bed. And then we also recommend elevating the head of the bed on 6 to 8 inch blocks, just to keep the body positioned upright somewhat, and that also helps with preventing GERD and the reflux into the airways. So thick feedings for infants, elevating the head of your bed 6 to 8 inches, loose clothing, eating smaller, more frequent meals. Weight loss can also help significantly with GERD. And then there's very effective pharmacotherapy, which I won't go into here, and in refractory cases, there's actually a surgical procedure to help. Respiratory infections, we know that these are very common, and they are at risk in patients with asthma because it can increase the airway hyperresponsiveness for weeks. As I said, I had a cold a month ago. The cold symptoms are long gone. At this point, I'm still suffering 4 weeks later with some residual asthma symptoms because my airways are still not back to baseline yet. So proper nutrition and rest, the annual flu vaccine, good hand washing, keeping the hands away from the face in children because we know that these viruses can enter into the nose and into the mouth and into the eyes, avoiding those who are actively sick, and then using antibiotics, really reserving those for when there is a bacterial infection that would be appropriate. And we're going to finish up finally with asthma in pregnancy. So multiple studies have examined the outcome of asthma in pregnancy, and there is it's an asthma in third rule. So we know that asthma status during pregnancy, a third of the women who have asthma and get pregnant, their asthma will worsen. A third of the women with asthma their asthma will stay the same. And a third of the women with asthma, their asthma actually improves during pregnancy. The problem is we don't know how to predict which third you're going to fall into if you have asthma and you get pregnant. So a third get worse, a third stay the same, and a third get better. Most asthma medications are as safe to use in pregnancy as in the non-pregnant state. The last thing you want a woman to do is to stop her asthma medications. That's kind of a knee-jerk reaction when someone gets pregnant. They stop all their medicines. I don't want to take anything I don't have to take. And then they lose asthma control. So there certainly are medications that are thought to be safe to use during pregnancy. It is paramount to keep the asthma under control. So budesonide is preferred ICS agent because there's more data on it. But if they're coming into the pregnancy and they're already on an inhaled corticosteroid or a combination inhaled steroid long-acting beta agonist, we would not stop that medication if that was what was keeping them under control. So if they were well controlled on those agents, we would allow them to use them during the pregnancy. There's little data on leukotriene receptor antagonists like Singulair and Zyflo, but there's reassuring animal data. And the long-acting beta agonist safety profile is very similar to albuterol. So it is, again, and you'll hear me repeat this a couple times, it is safer for a pregnant woman with asthma to be treated with asthma medications than to have asthma symptoms and an exacerbation during pregnancy. So the goal is to maintain sufficient lung function and blood supply and blood oxygenation to ensure adequate oxygen blood supply to the fetus. That's paramount. That's number one goal. And for most medications used to treat asthma and rhinitis, there are little data to suggest an increased risk to the fetus. So treating asthma is paramount. We always would prefer inhaled medications to oral because you get just the localized effect rather than systemic. Now, having said that, there are a couple medications with some possibility of risk to the fetus, and those would include decongestants. We wouldn't want someone to take a decongestant during pregnancy, and some antibiotics, some live virus vaccines, brompheniramine, epinephrine. There certainly are some medications, but for most of the typical allergy and asthma meds, and this would be something that a pregnant woman would want to review with her allergist or her pulmonologist or her primary care provider or her obstetrician, just to review the medications. But I would say that most of them, if they are well controlled on these medications, we can certainly step down if they were doing well, but we would want to keep them on the medications that would control their asthma throughout the course of the pregnancy. So again, most asthma medications are safe to use in pregnancy as in the non-pregnant state. The key to asthma control during pregnancy is taking the medications as prescribed, avoiding asthma triggers, following an asthma action plan so they can jump on and escalate that therapy if they need to at the very early sign of trouble, because the last thing we want for them is to have an exacerbation that would require an emergency department visit or hospitalization. And they need to be seen regularly by their provider more frequently if their asthma is not controlled. So the known risks of uncontrolled asthma are far, far greater than the known risks of asthma medications for both the mother and the unborn child. And asthma during pregnancy can be controlled. That should be an expectation that we can keep asthma under control during pregnancy. And pregnant women with asthma have the same outcome similar to the general population. Now, as I said before, we want to try and limit medications during pregnancy, but there are therapies that are considered safe to use, and we may not want to step down therapy when a woman becomes pregnant if they went into that pregnancy well controlled and they've needed that certain regimen to keep their asthma under control. So it's safer for pregnant women with asthma to be treated with medications than for them to have asthma exacerbations and to have that impact the oxygen level to the fetus. So that is all I have, and I thank you again for your attention today. I'm pleased to provide these slides to you as a reference, and we will next time be talking about asthma action plans, and then we have a couple of COPD webinars after that, and we have a few minutes left to take questions.
Hi, Karen, it's Sue. There is one question here wondering about resources for folks that have Medicaid that might have a cockroach issue in their home. And then there were a couple of comments after that, and one comment was, I wonder about adult protective services. So what are your thoughts on that?
Yeah, so for cockroaches in the home or other asthma triggers for children with Medicaid, there are resources. Now, I know that there could be participants from all over the state. I know that in West Michigan, I would check with your local asthma coalition. There are asthma coalitions scattered throughout the state. They would really know about those types of resources. I know that in West Michigan, we would often work with integrated pest management, that like a Healthy Homes Coalition. They would come in and we would work together, and they would help provide these services free of charge to many of these families, where they would set gel traps and that sort of thing, and they would treat these roaches and roach infestations in a more environmentally safe way than coming in as a exterminator might. Now, in some cases, that's still necessary, but oftentimes integrated pest management can be highly effective. And there are many Healthy Homes coalitions, asthma coalitions, that can at least steer you in the right direction, or perhaps even provide those services for you. The other question about Child Protective Services, that is a good question. I'm assuming at that point you might be talking more about smoking cessation than cockroaches. I don't know. Talking about cockroaches, another way to get involved with that, though, if there is a cockroach infestation, is to work with a landlord. And that could reach a point where we might need to get some legal advice if the landlord will not get in there and help remediate for the cockroaches. Child Protective Services, I don't know that would be an issue if the family was doing what they could to eliminate those cockroaches, unless obviously there was perhaps a hoarding situation and that sort of thing. For Child Protective Services for smoking, As I said, if we can get an objective measurement at the cotinine level, I remember that there was one young girl who every time she went to her father's house over the weekend and then the grandmother would pick her up, the child would have an exacerbation after being exposed to smoke in the father's home for the weekend. And we sent the grandma and the child in for a cotinine level test done. And then based on those results, if it does reach a certain level, and I couldn't tell you offhand what that level of detection was in that situation, but at some point it does reach the level where we could have a case for medical neglect and get Child Protective Services involved.
And there was one response here. It sounds like it was in relation to the initial question. I'm not sure if this is a typo. It says member has a Taylor and he is an adult, so maybe he is a Taylor. So Healthy Homes does not work with adults. Asthma Network was asking if Priority Health had any resources. Oh, trailer. Oh, member has a trailer.
Trailer.
There we go. That makes more sense. Okay.
I would, well, I would always, if the member has, an insurance company and there is a care manager assigned, I would work with that care manager at the insurance company because they also have resources that they are well aware of regarding the, respective community that the individual lives in. So I would touch base with the care manager either at the point of care in the provider office if they have one, or at the insurance company, and I think that they could provide some value and insight as well.
The other is, I don't know if they still have it, but at one point the Michigan Department of Health and Human Services, so if you went to MDHHS, they had resources and contacts in the different regions of the state as well. I'm not sure if you're familiar with that, Karen, or not.
Again, the Michigan Department of Health and Human Services would direct you towards the local asthma coalitions or towards the local Healthy Homes coalitions. And so that might be a resource for you. The other thing is to go into the website, getasthmahelp.org, which is the state website, and that can give you some insight into how to manage certain asthma triggers. But for resources, and one other thing that you might want to look at is the EPA website, and that is asthmacommunitynetwork.org. And that will also tell you what other resources are available in your community. But I would start with the Asthma Coalition, Healthy Homes Coalition. I would work with care managers or social workers who might either be at point of care in the provider office or the health plan. I think that Michigan Department of Community Health, the website, getasthmahelp.org, EPA website, I mean, there's just a wealth of resources available. The EPA Asthma Community Network website, I think there's a lot of resources available out there. And if someone has a specific question or need, they can reach out to me and I can certainly help them track something down.
Thank you so much. Very helpful.
Sure.
Just see if we'll give a minute. Anyone else has questions? Not seeing any right now. Nothing's coming up, and we are at the end of the hour. So thanks again, Karen. Another great webinar, great information, a really good practical application for the care managers and care coordinators on the phone. So once again, thanks, and we look forward to the next webinar.
Thank you, Sue. Thank you, everyone, for listening today.